Good morning, everyone. Welcome to our Wednesday talk. Our presenter today is Dr. Michelle Himan. She is a qualified haematologist currently working at Ampath laboratories. She has an interest in coagulation as well as in veterinary pathology. She attended the University of Pretoria and obtained her degree as in BSc Human Physiology and Bachelor of Medicine and Surgery. She completed an internship in community service at Tembisa Hospital, and in 2021 she completed her postgraduate studies in haematology at Sefako Makgatho Health Sciences. Thank you.
Thank you, Leanne. Okay, so today I'm just going to discuss about plasma cell dyscrasia. It's just going to be a touch on it, and also just to recap for all the doctors, if they do if they do see a patient complaining of chronic back pain, and all the signs just to look for in a patient that you want to exclude a multiple myeloma in. So the outline for today is I'm just going to talk about the definition. And I'm also going to recap hematopoiesis so that we can see where the cells are being produced and where the mutation occurs leading to this plasma cell dyscrasia. And then I'm going to talk about the disease entity of how it starts, starting with monoclonal gammopathy of undetermined significance, moving over to a smoldering multiple myeloma. And then at the end, the patient will present with a full-blown symptomatic multiple myeloma. So I'm going to recap again the pathology, the presentation, the investigation, staging, and I'm going to touch on the management. And then just a summary at the end. So what is plasma cell dyscrasia? So plasma cell neoplasms, they are clonal B-cell tumors that range from a stable disease without any functional abnormalities. And that's what you call your MGUS. And they slowly proliferate, gaining abnormal molecular mutations, developing in full-blown symptomatic multiple myeloma. And then when your plasma cell burden is increased, the patient will present with end organ damage. It's the CRAB criteria we're referring to, and the patient will fulfill diagnosis of multiple myeloma. So it will fall under the plasma cell dyscrasia. As you can see, it will fall under an umbrella term of multiple disease entities, but today we're going to focus on the multiple myeloma. So the normal bone marrow function. So first of all, it helps with the production of the red blood cells, your white blood cells, as well as your megakaryocytes. That's the precursors of cells producing your platelets, and then your plasma cells. So within the bone marrow, it's usually between 1 to 3% plasma cells that we can say are normally produced within the marrow. So if we do examine bone marrow, we see there's an increase in the plasmacytosis. We have to think about excluding a plasma cell dyscrasia. Of note also to remember that plasma cells do increase in patients with HIV. It would be reactive due to the viral infection. And actually, in an HIV patient, you can see a plasma cell cytosis ranging from 30 to 60%. So it's quite alarming and you do get a fright. But then if you go and look if these cells are clonal, you actually see that they are reactive. And I'm also going to talk about how we investigate to prove that these plasma cells are actually clonal. So this is just a recap, just to explain to you guys an overview where we're going to talk. So we get our bone marrow stem cell, and it will produce into a myeloid stem cell or lymphoid stem cell. From your myeloid stem cells, we'll get your red blood cells, as well as your megakaryocytes, and then your white blood cells with all your granulocytes. And then if we move to the lymphoid section, you'll see that you'll make B lymphocytes. If your B lymphocytes terminally differentiate into plasma cells, these plasma cells will then produce immunoglobulins. And somewhere in that maturation process, a mutation occurred, and you'll sit with a plasma cell producing one type of antibody. And that antibody is what we will detect in the serum-free light chain, as well as the SPEP, or the serum protein electrophoresis. The other leg of your lymphocytes is your T lymphocytes and your natural killer T cells. But we're going to focus today on the plasma cells. So how does it work? Your immune system differentiate or make B cells. Post-germinal B cells, after stimulation, a vaccine or exposure to a viral, you'll then produce your plasma cells. Your plasma cells are then programmed cells that produce your antibodies. So your normal antibody will consist about a heavy and a light chain. And this is actually what we also use to detect the clonality of the cell. If you're producing an abnormal immunoglobulin, we'll see that you'll have a peak in a heavy chain of a certain subtype, as well as you'll see your kappa and lambda light chain ratio will be skewed. And this is because there will be an abnormal amount of a certain type of antibody being produced. Also to note that these antibodies are non-functional. So if you do your kappa to lambda ratio, you'll see that it's abnormal, and it will give us an indication that we're sitting with a patient producing an abnormal clone of immunoglobulins. So like I told you guys, we'll get our B cells within our bone marrow working together with our T cells that actually have receptors on them, binding to the viruses or vaccines, talking to our B cells, or B cells differentiate into memory cells or plasma cells, and our plasma cells are then the cells producing our immunoglobulins. And that helps us to fight an infection. But what happens if there's a mutation going haywire in your plasma cells? It means that they are producing one non-functional immunoglobulin. And that immunoglobulin is actually causing the symptoms, as well as these plasma cells that proliferate, not dying, overtaking your bone marrow, and the patient will be sitting with a full-blown symptomatic plasma cell myeloma because these plasma cells are actually disrupting the normal bone marrow function. And we can detect these immunoglobulins on a serum protein electrophoresis, as indicated by that red peak on the SPEP. That will give us that indication that there's an M protein in the gamma region. So there's an abnormal immunoglobulin clone being produced. And like I mentioned to you before, I'm going to repeat this maybe once or twice again. So what happens if your plasma cells are just proliferating, extension, or taking over your bone marrow? Well, first of all, it's going to expand and take up the other areas of the bone marrow needed for production of cells, like your red blood cells. So you'll present with an anemia. Because these immunoglobulins are actually now also in your serum, it will go and deposit on your kidneys. You'll present with renal failure or renal abnormality, with your creatinine being sky high. It's one of the criteria for diagnosis of a multiple myeloma. And also your tubules will actually absorb your serum-free light chains, but only up to a certain amount. And then you'll actually excrete all these free light chains. And that's what we can detect in the urine as well. And because your plasma cells are actually stimulating your osteoclasts, so those are the cells that break down the bone formation, you will present with bone pain, as well as also lytic lesions, and you can present with pathological fractures. And because these plasma cells are stimulating your osteoclasts, they break down your bone, you'll get an increase in calcium. So what is MGUS? I'm going to talk about monoclonal gammopathy of undetermined significance, and I'm going to name it MGUS. That's what we actually just call it. So it's an asymptomatic pre-malignant stage. So it's actually not quite scary. It's usually present in 3% of the population above the age of 50. And it progresses to multiple myeloma at a rate about 1% per year. And while we diagnose this, it's actually accidental. The patient will come and you'll do an SPEC, and we'll see that this monoclonal protein is less than 3 grams per deciliter. If we then go and investigate this patient, because you'll have to see if you detected something abnormal, we have to exclude a plasma cell dyscrasia, we'll do the bone marrow. And in the bone marrow, we'll see that there's less than 10% plasma cells. We are also then correlated with all the other functions like red blood cell count. We'll make sure that the patient is not hypercalcemic. We'll look at the creatinine. And we'll also examine if there's any hyperviscosity syndromes, signs or syndromes like dizziness, headache, loss of balance because of this immunoglobulin protein in the serum. So we'll start working this patient up. There will be no CRAB criteria because the plasma cell burden is too low to cause end organ damage. So it's usually present in the older group of people. It's twice as more common in men compared to women. It's also more common in African American population compared to the Europeans. And also there's a genetic predisposition. So if you have a family member with a plasma cell dyscrasia, you've got a higher risk, about 4% more chance of getting a plasma cell dyscrasia like an MGUS. There's 3 types of MGUSs you can detect, and this is usually with the type of immunoglobulin. So the non-IgM MGUSs will be your IgG, A or D, as well as the IgM MGUS, and this will also actually examine the patient and we'll look for a clonal population of lymphocytes as well to fulfill the criteria of a Waldenstrom macroglobulinemia. And then you can also get a light chain MGUS, and this is where there's only a light chain abnormality detected and not a heavy chain. The problem with this is the light chains can actually also go and deposit on organs, causing a light chain multiple myeloma or amyloidosis. So how do these patients present? MGUS are usually supposed to be not presenting with some symptoms. They can have slight symptoms because of the monoclonal protein, but quite interesting, most of these patients will go to a doctor with some or other skin rash or peripheral neuropathy, or complaining about tingling or numbness. I had a young lady the other day that was seen actually, and they did an SPEP and we detected a monoclonal protein, but her main complaint was actually a rash. And then at the end of the day, we diagnosed her with a smoldering multiple myeloma, and she was 40 years old. So the presentation of these patients are also becoming younger, according to, and not corresponding with the textbook pictures. So it's also important if patients do complain about something and you do an FBC and they can say, actually, there's a rule of information I want to talk about, it's nice to actually just do an SPEP because this lady will now be monitored because she's got a risk of progressing to a multiple myeloma. And the investigations that we'll do, we'll have to, every time you have to do a full blood count, and this will just be to monitor your patient's hemoglobin. Your calcium also, to exclude hypercalcemia. Renal function test is very important to monitor your creatinine. And then always, like I told people, is a SPEP. There's no set guidelines that I looked about if you do get a patient with a MGUS or smoldering multiple myeloma. I think you'll have to also go on the patient's clinical presentation, and you can maybe initially do an SPEP every 6 months if there's no signs or symptoms. And you can also do the serum-free light chain ratio to detect if that immunoglobulin burden is increasing. So with the FBC, what we do in the lab is what we detect is, so you'll see on your left side, this is a normal FBC. You can see the red blood cells are not touching one another. There's a little bit of space between them. It's because red blood cells have got a negative charge repelling one another. And that is a lymphocyte in there. Then we move to this slide. This is now a patient with an increased M protein. So there's immunoglobulins within the serum. And as you can see, because the serum is so thick, it's actually around these red blood cells. It's causing rheostatic effects. So the negative charge of these red blood cells are actually being repelled and they stick to one another. And you do get this coin stack appearance. And that is what we actually look at under a microscope. And this will give us an idea that we may be sitting with a patient that's got a monoclonal protein in the serum. And this is just a picture where you can see nice ruler formation and compare this background to this background. You can see that there's a bit more background staining. And there's a nice plasma cell within the peripheral blood. That's also rare that you're not supposed to see. So it is alarming that you want to investigate this patient. So, like I mentioned before, this is just going to be a recap. You're just going to actually then work up your patient, look at the FBC like I mentioned. We're going to do the marrow. Then it's also important to do just cytogenetics initially when the patient presents to you, and FISH. The reason why we'll do this is just to detect any other abnormalities, and also FISH these prognostic markers. Some of them are going to mention now, but later, that's going to have an increased risk of progression to multiple myeloma. So those patients you have to monitor closely. This is just a picture of a bone marrow. So we'll make bone marrow smears and assess the cellularity. And then we'll actually start counting the plasma cells. We'll do about 300 to 500 cell count. And in that population of cells, we'll estimate your amount of plasma cells. We'll also then move to a trephine biopsy. A trephine biopsy is very important in a plasma cell dyscrasia, and the reason for this is you get a bigger overview of how the bone marrow is functioning. So you can also assess cellularity. You can look at your bony spicules, that's viable, but then also some areas you can see that maybe there'll be a more prominent increase in plasma cells. And I've also had trephines where it looks normal cellular, then there's 1 or 2 marrow expanses that's got a sheet of plasma cells. So that is also worrying. So you get an overall picture of your bone. And then what do? You'll have to monitor these patients because they're going to, in the future, they can complain about bone and back pain. Because this monoclonal protein that's being produced or the immunoglobulin is non-functional, they'll present with infection. So it's also best to educate these patients to go for their yearly flu vaccine because they have an increased risk of being susceptible to infections. They can also then present with any other symptoms like anemia, bleeding, fatigue, and night sweats or fever. And this is actually just what the presentation is about. So I spoke about INGAS, how it all starts. If you do then your bone marrow and you see there's more than 10% without any end organ function, it will fulfill the criteria of a smoldering multiple myeloma. If you then move and you see that there's still more than 10% of plasma cells, but there's end organ damage, it will fulfill the criteria of a multiple myeloma. Also note that if your plasma cell percentage within the bone marrow is more than 60%, it is a multiple myeloma. And if your serum-free light chain ratio, like I mentioned in the beginning, is skewed, like it's more than 100 kappa or more than 100 lambda, it also will fulfill the criteria of a multiple myeloma. It's also important to look for lytic bone lesions because that is also one of the criteria that you need to exclude end organ damage. Okay, so I'm quickly going to talk about the smoldering. So as you know, when there's more than 10% plasma cells, and these patients, they have a rate of approximately to progress to multiple myeloma at 10% per year over the first 5 years of diagnosis. And thereafter, it will actually decrease to 3% in the next 5 years and 1.5% thereafter. So if you do have a smoldering multiple myeloma, it's best to monitor your patient before they've developed end organ damage. And the reason why it's important if you do detect a smoldering multiple myeloma to do FISH, it is just sometimes the FISH will give us a prognostic indication. If you present with a translocation 414 or deletion 17p or a gain of 1q, they are at higher risk of progressing to a multiple myeloma, and these patients should be monitored very closely. There's a new, I think Dr. Jim was actually on it, the new International Multiple Myeloma Working Group, where they actually try and focus now on monitoring these patients more closely. And I think they're also talking about maybe starting treatment earlier in these patients to prevent end organ damage. So in here, the smoldering is just again the classification. You'll see that the end protein will be slightly higher, more than 10% of plasma cells in the bone marrow. It will be less than 60% because if it is more than 60, the criteria for multiple myeloma will be met. So that is the diagnosis of it. The new WHO actually mentioned a new entity of a plasma cell dyscrasia, and they call it monoclonal gammopathy of renal significance. So they did enter this section in the textbook, and how this differs from a smoldering NGAS is you need to actually do a kidney biopsy and show that those immunoglobulins actually caused damage on the renal or on your kidney, and that will actually then fulfill the monoclonal gammopathy of renal significance. So a biopsy in these patients are suggested to fulfill this criteria. Then I'm going to go to what the presentation is actually about, and it's about multiple myeloma. So like I said, it's where your plasma cells go haywire. There's a mutation. It's usually occurring where the immunoglobulin heavy chain, where the light and heavy chain undergo somatic hypermutation, and it occurred while you're producing this immunoglobulins. So your plasma cells are not dying, they're overproliferating, and they're producing one type of immunoglobulin. And you'll present with end organ damage. So multiple myeloma accounts for 1% of all malignant tumors. So this actually sounds rare, and it is rare, but we see it a lot. Of all the hematological malignancies, it comprises 17%. So I think if you talk to any hematologist, you diagnose about 2 to 3 multiple myelomas every week. It's quite prominent in our population. I think it's actually increasing. They usually, and according to the textbooks, they say the median age is about 65 to 70, and they say a small percentage, 2%, is less than 40. But I don't agree with this. I think in our South Africa population, we see a lot younger patients with multiple myeloma. Unfortunately, men do still present, but we do get it in a lot of females. It's twice as common in the African population, like I mentioned in the NGAS, and then it's actually quite lower in patients from Japan and Mexico. So they have correlated that there's some toxins that can increase your risk to getting a multiple myeloma, like dioxins or radiation exposure. But most likely, they say that the mechanism of myeloma is still largely unknown. You've got a family risk up to 4-fold, like I mentioned, if you have a first-degree relative that's been diagnosed with a plasma cell dyscrasia. But then also there's an increased risk of myeloma if you do have autoimmune diseases like rheumatoid arthritis or pernicious anemia. And then a very, very large population of our HIV patients do get a multiple myeloma. So the pathology of multiple myeloma is quite interesting and complex. So I made it one slide just to understand it better, but these plasma cells accumulate within your bone marrow, and they stimulate your microenvironment to secrete cytokines. It could be interleukin-6, NF-kappa B, and they actually promote their own survival, and they actually go in your bone marrow and hide so that there's no other cells willing to kill them, and they stimulate themselves to proliferate, get more. They also secrete interleukins and tumor necrosis factor alpha and RUNKLE, that's to activate your osteoclast, like I mentioned before. And these osteoclasts just goes and eats the bone non-stop, causing hyperkalemia, bone pain, decrease in your bone density, and then the patient will present with lytic bone lesions and pathological fractures. So what they actually do is they uncouple the resorption and the breakdown of bone due to the skewing of your osteoclast and osteoblast ratio within the bone marrow. And this is just a picture of what these plasma cells actually do. So I did mention it. They destruct your bone, breaking down the bone. They also produce non-functional immunoglobulins, so you present with an infection. And also these monoclonal proteins can cause hyperviscosity, renal failure, and they can deposit in organs. And at the end, they could also cause amyloidosis. So patients usually that's got multiple myeloma, they present, and one common symptom that they complain about is back pain. Back pain and rib pain, because some of these lytic bone lesions will go to the back, it can cause compression, it can cause nerve damage, and also then they can actually also struggle with breathing because of these ribs that's got pathological fractures. They're going to get an increased risk of chest infections. So when you do your X-ray, you can actually detect the lytic bone lesions. But most of all, it will be bone pain. They'll be fatigue because they're anemic. They'll present with recurrent infections. Because of this protein or the monoclonal protein in the blood, it actually also affects your platelet function. So they've got an increased risk of bleeding. They can also present with hypercalcemia. And then at the end stage, they'll present with features of renal failure. So how do we investigate these patients? I'm just repeating myself, but it's going to be nice to get in history and examination and to screen. Do again what I mentioned, FBC, look at the morphology. Very important, do your SPEP and immunofixation, do a serum-free light chain ratio, monitor the creatinine and calcium levels. Very important in these patients is also just to exclude any nutritional deficiency. Because remember, if you have to fulfill the criteria of a multiple myeloma, the anemia must be attributed to the plasma cell burden. So a few times it happened before that I get a bone marrow where the patient has got depleted iron stores, the HB is low, but there's also plasma cell burden within the bone marrow. So is this plasma cells causing the anemia, or is it actually the iron deficiency? So sometimes it makes it difficult then to fulfill the criteria. And you have to tell the doctor to treat the iron and monitor and see if it goes up, if there's enough bone marrow reserve producing red blood cells. And then you'll do your ESR, as well as your total protein, your beta-2 macroglobulin, LDH, uric acid, also a septic screen. These patients are at risk of infections, and exclude an HIV viral co-infection. I'm not going to repeat myself, but yes, this is what we're going to look for in a multiple myeloma. Usually these patients will have a lot of background staining and rouleau formation. We're going to do our SPEP, and this is just to show that in a multiple myeloma, our IgG is usually most common, 50% of a multiple myelomas, followed by IgA, 20%. And then we can get also just a light chain multiple myeloma of 20%, the IgG 2%, and IgM very rare 0.5. But very important to do your SPEP and immunofixation. Then if there is any lymphadenopathy or a mass on the patient, it's very important to biopsy it to exclude a plasmacytoma in this patient. So that will be a mass just producing abnormal plasma cells producing the immunoglobulins. Then it's important to do a bone marrow. Like I mentioned, we just want to see the disease burden within the marrow as well as the trephine. Very important is immunophenotyping. This is what we use to confirm that these plasma cells are clonal. We're going to do karyotyping. It's very nice to have an initial karyogram of a patient that's been diagnosed with a plasma cell dyscrasia. It also helps to follow up and see if there's additional mutations occurring. And then FISH is also to monitor for prognostic value. And this is just again a picture. This is a normal bone marrow where you can see your granulocytes, nucleated red blood cells. And then in a picture here where you can see these abnormal plasma cells. And just by scanning this slide already here, you can see it's more than 10% of plasma cells. And a plasma cell is identified by these cells having an eccentric nuclear, and then there's a small space with a white area they call the perinuclear half. And sometimes within these cytoplasm, you can see actually globulins of white areas. And that's actually where your immunoglobulins are still within the plasma cells. You can then also just see that. This is just a picture out of the WHO. I'm not going to repeat it again for fulfilling the criteria for a multiple myeloma. I did mention it. This is a new updated WHO classification of multiple myeloma. As you can see there, is they give you actually the estimated amount of hypercalcemia. If it's more than 2.75 millimoles per liter. Very important, look at the creatinine ratio. It's more than 177 micromoles per liter. So sometimes it's difficult. You'll see a patient with a mild renal dysfunction, but not fulfilling the criteria of multiple myeloma. And in those cases, it would be nice, if possible, to do a renal biopsy to diagnose the new entity of the WHO, where they're actually diagnosed with the renal abnormality. Like I mentioned before, just remember MGUS has got no CRAB criteria. Your smoldering has also got no criteria. And when you do present with a multiple myeloma, you'll present with your criteria. That's the anemia, renal dysfunction, hypercalcemia, and bone pain. I just put this in for interesting sake and for all the doctors that does not know the principle of flow cytometry. So this is an amazing machine that we actually use to analyze all the cells within a bone marrow, and we can use it on the peripheral blood if the bone marrow sample is not sufficient. How it works is it actually has 3 sections. It's fluidic. So what it does, it transports cells in a stream of laser beam being monitored. So that means your blood is being one cell at a time being looked at, the complexity, its size, and then what type of receptors is on that cells. The machine also works then with optics, different lasers that's being detected by different wavelengths. And we actually then have monoclonal antibodies that bind to certain cells that's going to be excited when a type of wavelength hits it. And then electronics, where we actually convert these wave-light energy into a digital signal in a computer scatter plot, where we then analyze it. And this is just a picture of how I want to show that the laser beam will actually hit your cells. And remember, there's different cells in your bone marrow. So it will hit the cell and it will get a forward scatter. Forward scatter will just give us an idea of the size of the cell. But then if the light hits it at the side, you'll get the complexity of the cell. This will be due to different scatter properties when the laser hits the cell because of the granules. So you can actually see more complex cells will have a bigger side scatter. And then electronically, you'll get actually a scatter like this, and it will indicate to you your cells. We use a CD45 just to gate all our cells because CD45 is bright in your lymphocytes. And I just want to show you it's a CD45 over side scatter. Like I mentioned now, side scatter is the complexity. So these cells that's a bit bigger, more complex, is your granulocytes because they've got all the granules supposed to fight your infection. So they're a bit more complex, and we actually know to gate them there. These purple population will be your monocytes, these bright CD45 smaller cells, your lymphocytes. And then here we'll see a funny population of cells that's usually CD45 negative, and we'll use other markers, but this will be your clonal population of plasma cells. And that's why flow cytometry is so important, because when you do get an abnormal population of plasma cells, the entire process of how the B cells from production to memory B cells to producing plasma cells, a mutation occurs. So because CD19 is a B cell marker, your abnormal plasma cells loses CD19. It gains CD, or it still will present with CD38 or CD138, but then also additional markers will be present in these plasma cells. And that's how we can detect that these cells are actually clonal, abnormal, not normal plasma cells. And this investigation helps us a lot to confirm that the cells we are seeing is abnormal. We then do cytogenetics, and this is also just to refresh people. I'm not going to go into detail, but this actually gives us an overview of the entire patient's chromosomes. So it's a karyogram, this, and you can see there's 2 pairs of chromosomes of everyone. So it's very nice to have it on your initial patient to actually detect what is going on. In this patient, we can see that there was actually a deletion of 13, small arm of 13q. And we can actually just build up also, a history of patient, because these plasma cells has a risk of actually being sensitive to going other mutations. It's nice to monitor these patients because they can get additional translocations in the future. And this is just the standard risk factors that we do. We can detect that some of these patients can present with a trisomy 12, extra chromosomes. They usually have a standard risk being hyperdiploidy. If you do detect a translocation 1114 or 614, it's standard risk. And then there's other abnormalities that put these patients at very high risk. Is the 17p deletion is your tumor suppressor gene, as well as translocation 414, 1416, and 1420. So I just want you to see that chromosome 14 is involved in all the abnormalities of a plasma cell. And it's because it's the heavy chain of your immunoglobulin that the switch occurs, causing the haywire of the production of the immunoglobulins. and we'll look at it. So you can see when the plasma cells were produced, somatic mutation occurred, causing the increased production of non-functional immunoglobulins. And in fish, just an example, they use specific markers, like in that translocation 414. The green is just to identify your chromosome 14, and the red marker or probe will be your chromosome 4. So what FISH does is, you can see that these two are not correlating to one another, but a mutation were detected. You can see they're close to one another. It shows that a part of chromosome 4 and 14 has fused, causing these mutations. And this with the lesion P53, here we can just see that it's a small arm of chromosome 17. Here's only one picked up in 2 green pieces. So it shows that there's a deletion of that part of the chromosome. The X-ray imaging, so first of all, if they do present with lytic bone lesions, causing this punched out appearance, as you can see in your skull. Also, then you can do other X-rays where you can detect pathological fractures. You can do an MRI, we can see this vertebral compression or collapse of your lumbar vertebra leading to compression, and the patient can present with paresthesia or neurological signs. Very important to do your bone scans. For the doctors that actually assess these patients with treatment, we use the revised international staging system, and that's why the beta-2 microglobulin and albumin and LDS or LDH with your cytogenetic markers are important, because they will classify these patients in stage 1, stage 2, and stage 3. So the management from any doctor's point of view is going to be supportive. To do blood transfusions. You can actually also, if the patient struggles, remember the immunoglobulins cause renal dysfunction, the EPO can't be produced anymore. These patients can be assisted with EPO injections. Infections, treat the infections, also prevented with vaccinations. Patients are in pain of the bone pain, treat with analgesia. The renal dysfunction, you have to correct the electrolyte imbalance and also hydrate the patient. With the bone pain, you can treat it with bisphosphonates. Also give supportive devices for the patient, and physiotherapy is suggested. And if the patient has a lot of hyperviscosity signs or symptoms, a plasma exchange could be needed. And then the orthopods will be involved with any major spinal cord compression. I'm not going to go into too much detail with the treatment. I think this year there were a revised multiple myeloma group, where they actually said that quadruple therapy is actually the best in a patient. So to start with 4 types of drugs. So it's best to make sure that your department follow the SOP with the new updated treatment regimens available and new drugs. So this I just put in for completeness sake, but I do feel every department will have their protocol that they will follow. This again there, and then also just how do we monitor a patient? Of course, it's very difficult if you start the patient on induction. We want to actually see how these serum protein electrophoresis, or they're actually increasing, how did the patient respond. So as you can see here in the bottom with partial response, you'll see that the serum M protein, if you do your SPEP and immunofixation, there will be a decrease in it. And then you can actually monitor your patient of how the urine protein decrease, and you can classify the patient in a certain category. So just a summary, multiple myeloma is common. It's common in older patients, especially men from African descent. They're often symptomatic with PrEP features. Very important if a patient complains about back pain, an older gentleman. It will be nice to successfully work this patient up into an SPEC. It's also nice to do serum testing and to monitor these patients in view of disease progression. Remember that there's also an emergency to recognize the spinal cord compression, hyperviscosity, and hypercalcemia. The survival of multiple myeloma, they are improving now to 8 to 10 years of a median overall survival. Treatment is generally long-term. As you know, there's no set of cure for a multiple myeloma. The patient will be cured and they will be monitored to response. Some of these patients do get stem cell transplant and they do better, but it's also a difficult disease to cure. There's also a lot of new monoclonal antibodies, CAR T stem cell CAR T cell treatment, as well as bispecific, trispecific monoclonal antibodies on the new horizon for treating multiple myeloma. So there is hope for these patients, and I think for us it's just to detect them early and to monitor them, not to miss them before they develop a full-blown multiple myeloma. Thank you. That's my part.
Thank you, Michelle. This was quite really good presentation. I've just two simple questions for you. The roles of SPEP in diagnosis of multiple myeloma, is it a screening tool or is it diagnostic?
It's both. So it will be best to have it. It will be a screening tool because if you do have a patient and there's no monoclonal protein, you can be a bit relaxed. But if there's still an M protein less than 3, the patient can present with an MGUS. Then it will be best to do the bone marrow and see where we're at.
And in the context of plasmacytoma?
A plasmacytoma will be
still be high.
Yes.
Yeah.
So you do your SPEP, and remember, a plasmacytoma can be anywhere in your body, your back. So that plasma cells can also produce this immunoglobulin, and that can detect in your serum. So say if you do get it in your serum, you do the bone marrow, but there's nothing in the bone marrow, it will be best to examine the patient for plasmacytoma for the area where these plasma cells are secreting these.
And then the second question really about the roles of Benz-John protein in the urine. That is normally a tool that we use for screening. Can it be diagnostic 100% certainty of myeloma, or can be a kind of different diagnosis because our presence of Benz-John protein is not specifically for myeloma, can also could be because of the amyloidosis.
Yes, so
the break.
it helps you to actually see that there's still those light chains being filtered through the kidneys in an extreme amount of time. Because at the end of the day, if your kidneys are not working, you're still going to detect it in your serum if there's an abnormal clone being produced. So it is helpful, but also to remember that it can occur in other plasma cell dyscrasias.
Yeah, so presence of basically what it's saying, presence of a Benz-John protein should point you to other possible diagnoses. And obviously you look at your amyloidosis, one of them, AL amyloidosis, and obviously myeloma is one of them. I think it's very, very important to always have a look at that. And then, bigger controversy, African population. Should we be doing SPEP on all of them, and what age would be specific?
So that's a bit difficult. I would say you do your FBC, and the morphology needs to be monitored. If you do see rular formation, background staining, do an SPEP. If the patient has HIV, I'll actually do an SPEP earlier in a patient from 40, just to make sure because they've got an increased risk of detecting or getting a multiple myeloma. It's very difficult, Emmanuel. I think you have to go with your patient's symptoms and signs because more younger people are presenting with MGUSs. So for me, I would say if I do detect or worry about something, I'll do an SPEP just to exclude it.
I think probably I just learned something new here, but we'll be looking at FBC and rural formation. I never really look at that. I think in our context as clinician, we have always looked at the liver function and looking at the total protein. And if, of course, it's very high, so most of the time then you do a screening, really looking for the myeloma. But also we, of course, in the context of HIV, most of them tend to have high total protein. And that's because of just a shifting of from low CD counts into other proteins that actually cause increase in the total protein. But again, I think as a screening tool is good, and we have seen a lot of myeloma obviously patients that are electrophoretic disease positive. So most of the time, I think you could look at two things: liver function and as Michelle has alluded to, the pleural formations. I think those are the things that we can look for. But again, multiple myeloma is a condition that is treatable really, and if it pick up early. And one of the patients yesterday asked me, said, "Doctor, help me. My friend had kidney failure, now he's on dialysis and everything. I'm 75 years old. Is there anything that I could do to pick up my kidney failure much more earlier?" And that's, for me, it was a very good question. And the question that what can you actually do? The question that there are a lot of factors that actually can affect the kidney. So sometimes anybody with acute kidney injury from age of 60, it's worth screening this patient for multiple myeloma, because sometimes you have really the early sign for them to present is going to be kidney failure actually than actually anything else. So sometimes I think it's good just to screen those patients a bit earlier. Yeah, and once they have back pains, it's really sometimes too late. So I think everybody actually need to be screened quite much earlier. And I always say that nobody dies and go to heaven. We die because we fail ourselves. And fail ourselves means we don't look after ourselves much earlier. The doctors fail us sometimes. They don't screen us earlier. They don't look at all those things, but we know that they exist. They're part of us. It's part of the human. It's part of aging process. And that's happened. So we need to kind of think about it. And this really, you can't substitute thinking, Thinking is something that is just necessary for any human to think. And as a clinician, we should be considering all this. And we should be doing, we're in South Africa, we should be doing more actual aspect of most of the patient screening from age above, 40 years. Could have been a good age, but we've also seen some incident multiple myeloma happening in the younger age actually group. So I think, unfortunately, that we don't have our own data in the country. Most of the data are really international, but it would be very nice for us to look at the incident multiple myeloma in South Africa, looking at different kind of racial group, because South Africa is a rainbow nation. We have a lot of multiracials. Would have been nice to see the incident all the racial group.
So one question. I see a lot of elderly patients, but also, so I often do the SPEP as part of their routine, yearly bloods. And so how do you think is the best way to kind of explain an INGUS to a person or patient? Because I deal with that every day, and you don't want to overly alarm them, and then you also don't want to, we want them to follow up, kind of. What do you think?
I would explain to them the role of your B lymphocytes stimulating your plasma cells. So there's one abnormality already detected, and it's very important for them to be monitored and before that clone starts evolving, producing too much. So they don't have cancer, but they have an increased risk of cancer. So that's why it's very, very important to monitor them. And so I would say that they need to continue enjoying life and stuff, but it's very important for them to follow up before something happens causing end organ damage. Sometimes they don't progress. Like you see, it's very low. So you have to explain to them the best for you would just be to follow up. You maybe will never progress to anything. And we've accidentally picked this up.
I think for elderly people, for the dangers, two things. One, the kidney failure that need to be picked up, because we know that from age of 60, you lose about 10% of your kidney. So perhaps once you pick that up, you need to kind of do your kidney function for maybe 3 or 6 months and correct them as early. And the second thing, of course, fear of anemia. Again, elderly people anemia, and if they syncope, they fall, they break bones. Again, then you have to look at that. Maybe next time we can look about indication of the transfusion, also maybe iron in those patients. And I think for me, that's how we look. But the question that quickly, no, James, you got a question. 80-year-old, can we do bone marrow on them? Is there a reason for us to do bone marrow on 80-year-olds, or we leave them alone? Can we?
Healthy 80-year-old, what is it? Because then you do a bone marrow and you'll see what's the disease burden. But I mean, if it's really a patient that's got dementia, Alzheimer's, 80 years, what is a bone marrow going to do on the quality of life of that patient? So I think every patient should be interpreted.
Okay, personalized therapy, obviously.
Okay, so actually, it's a response to a few things that have been mentioned. Remember the entity of the smoldering myeloma. You're not going to have a lot of M protein. There's a 2-20-20 rule. That's the old rule of the smoldering myeloma. You'll get 2 grams of an M protein. You need to do a bone marrow to see what the tumor burden is. So if the plasma cell is more than 20, right, or equal to 20, and then you've got the serum-free light chain, which you have to do. And if the involved serum-free light chain is more than 20, then the uninvolved, that already fulfills the 22-20-20 rule. And then you'll have to go further and look at FISH abnormalities. That gives an additional score. So in total, if you look at that score, the patient might warrant treatment, because depending on the score, from a score of 0 to 4, you can get a 3.2 progression to multiple myeloma over 2 years. A score greater than 12, you can get a 72% progression to multiple myeloma over 2 years. So I think in that case, your question about an MGUS, you need to monitor them at least yearly to 6 monthly, depending on the M protein that you see. We do the whole, the full myeloma panel on these patients on a regular basis to follow them. Obviously, if the cytopenias and target organ damage, that is late already. That's the CRAB criteria. If you remember the new revised IMWG criteria, you don't need to have the whole CRAB criteria or some of the CRAB criteria. But if you have the tumor burden, the involved serum free lighting, already skeletal, involvement with the MRI, that's enough for us to treat the patient. And then cytogenetics acts to the risk of transformation or progression. Remember, the other end of the spectrum is plasma cell leukemia. It's not that common, but I've seen it. And these patients, I had a patient who came in with an M protein and multiple myeloma diagnosis, high risk cytogenetics. We treated her 6 months, not even 6 months of treatment. She already progressed with plasma cell leukemia. And she she passed on. We tried to push her in for a transplant. We intensified the treatment to bring it down. She didn't respond. She didn't tolerate it. And she eventually passed away. And she was a fully functioning lady. Actually, she was a matron in one of the hospitals. So that's the thing. We have to have that in our mind. The rouleau formation and the total protein is a guide. I have diagnosed myeloma without so much of a total protein, just because of the other criteria. Yeah. So yes, it is something that is manageable. It should be detected early, and it needs the patient. In South Africa, what we do is we induce them with 6 cycles of chemotherapy, and then we consolidate them with a transplant, an autologous transplant, and they do pretty well. And then we maintain them and we monitor them depending on their response. And we have a lot of drugs. In the olden days, we didn't have any. I've had family friends who've passed on because they didn't have a treatment. Now there's a lot available. So as soon as you detect it, send the patient to a hematologist and let them start the process. Even the monitoring, it's not up to you. You don't have to take on that responsibility. Refer the patient immediately to a hematologist. That's their job, and they can help you out with that.
Yeah, I think that's really good. Thank you for that. It's always really important. And basically, I think the take-home message that I think when you look at your full blood counts, we are not hematologists. We need to look at the comments on the base, because real formation, you can only see that on the comments. Am I wrong?
Yes.
You won't be able to see it as a clinician. We're not even trained for that. So please do look at the comments from your fellow colleague and see what they're saying about, and then please take that comment seriously and make something. Remember, our roles as a doctors, we are there to provide solution to our patients' problems. And that means you cannot stop halfway. You have to go all the way to make sure your patient get the best. After all, they actually pay for your service for that. So imagine you're going to take your car and you get a half service. You're going to be mad. The same thing with the patient. Please do the right thing. Thank you.
So I had a doctor who asked, should they or should they not? When exactly should they opt for the biopsy? Because the renal dysfunction, like we say, as they grow older, decrease in renal function and stuff. So when exactly should they investigate that?
The rule it says that they need a biopsy to confirm this. So I would just
So I have seen a lot of patients sitting there with a grumbling renal function that's not optimal, and I refer them to nephrologists. Now I have to mention that the nephrologists differ. The one nephrologist did nothing and followed up the patient. This is not a multiple myeloma. It's not that, but it's another case. I had a patient who had a CLL that was on watch and wait protocol, and they had this grumbling renal failure. And I sent him to a nephrologist, a well-known nephrologist in Pretoria, because this was when I was in Mpumalanga. He saw the doctor. The doctor said, "Oh no, there's nothing much, nothing's wrong." Did a few basic investigations, and the patient followed on ongoing renal failure. And I see it's getting a bit worse. And then I spoke to a different nephrologist who I know, and they investigated further. They did a biopsy, and the patient had CLL.
You see the problem there with
So it's an SLL that they had of the renal system. And if you didn't do a biopsy, you wouldn't have known.
The problem that sometimes this patient, when they're having those symptoms with the renal failure, they're also having other comorbidities like hypertension, diabetes, and other things. And the problem with the clinician, always the dangerous clinician, is the one who knows it all. And the moment you reach an assumption that probably is because of 1, 2, 3, you really make a huge mistake, and obviously you send your patient 6 feet under. So the basis, I think, biopsy is very important. Once you have that bench joint protein or whatever in the urine, so it tells most likely it's more infiltrative, and most of the time I think there should be a way to distinguish is it tubular cause or actually glomerular cause of the really renal failure. And sometimes maybe biopsy for me is something that can be done really very easily and let the patient really on the coagulation, a lot of other issues. Then you get the treatment, because now once they have that infiltrates inside, the treatment is different. You can't really, if it's amyloid, you treat differently. If it's a myeloma, you treat differently. If it's hypertensive, you treat also differently. So all this we have to treat kind of different. So I think I agree with you. You have to get second opinion from second nephrologist, and that's, I think you shouldn't worry about that.
Have a good week.